Good afternoon. Welcome to Wonderful Wednesday. And today I'm going to review relatively quickly a case of undifferentiated shock in a Jehovah's Witness patient. Now, it's really important to know that he's a Jehovah's Witness, but it actually has no bearing whatsoever on the outcome of this case. Just important to know that the patient is a Jehovah's Witness. So as many of us can appreciate, when we receive patients who actually have strong religious beliefs about products that they can actually take, things like pork products, things like beef products, things like human products, it always makes us very tenuous and worried in our care, but it did not limit anything for this patient, nor did the fact that he was a Jehovah's Witness actually affect the outcome in this case. So just want to let you know this was just a way for me to identify this patient. So thank you again for joining. And my first concern and question would be, how is it that we define shock? So what we want to remember when we're talking about shock is it's not actually about blood pressure, even though so much of our focus is about restoration of blood pressure or mean pressure greater than 65, sometimes a little higher, depending on the patient's physiologic or pathophysiologic condition, but that it really is about whether or not you have adequate perfusion. So always important to remember the adequacy of perfusion is you must have an effective cardiac ejection. So that would be with each heartbeat would be your stroke volume, and your stroke volume times your heart rate is your cardiac output, number one. Number two is oxygen carrying capacity, which is your hemoglobin, which is one of the reasons folks were very concerned about this patient who's a Jehovah's Witness. He's supposed to have surgical repair. Can we get him to surgery and back without giving him blood? Blood carries oxygen. It's the second component in adequate perfusion. And then ultimately, of course, is the saturation of that hemoglobin. That would be your SaO2. So cardiac output number one, hemoglobin number two, SaO2 number three, and then something else. And that is the ability of the patient to maintain his vascular tone. So I really want to focus in this talk, and I won't really necessarily have a slide to support it, but I'm going to highlight things that we're looking at in our patient's case to be thinking about whether or not the patient could maintain his vascular tone. And what could we think about? What might we communicate? What might we consider if we are presented with a case that's similar to this? Not the Jehovah's Witness part, but just the part that the patient's in shock. Okay, so I want to remind you, shock is actually about inadequate perfusion. It occurs because you have inadequate oxygen delivery, or you have an inadequate vascular tone, or you have just plain inadequate cardiac ejection. Is it hypotension? Sometimes, but not always. So don't wait for falling blood pressure to help you actually advocate, diagnose, intervene with a patient who has shock. Now we think about differentiating shock states. I'm going to try to make that just as straightforward as possible for the four main types of shock. And they're the main types. I've given you a subset, and they're actually more than one subset. Number one, hypovolemic shock, pretty straightforward. Don't have enough volume. Don't have volume in the arteries, don't have volume in the veins, don't have volume in the interstitium. You are dehydrated. And then we talk about hemorrhagic hypovolemia. Hemorrhagic hypovolemia, you don't have volume in the artery, you don't have volume in the vein, you don't have volume in the interstitium, and you don't have adequate oxygen carrying capacity. Now, approaching a person with Jehovah's Witness, we're going to be very worried about hemorrhagic hypovolemia or just a low hemoglobin, because we can't replace your pack cells, because that's not allowed by the elders of your church, because it is believed to be sacrilegious to receive a human product. You know what? We're going to respect that. We're going to be aware of it. We're going to consider it. We're going to integrate that into our hearts. And we're going to approach those patients just the way we do with everyone, providing the best possible care, even though we can't give pack cells. And we don't talk about outside the room saying, oh, if he'd only gotten pack cells, he could have lived if he'd gotten pack cells. And in this case, that doesn't matter. But in other cases, it might be a consideration. But we're going to always support our individual patients' religious beliefs. We move from that hypovolemia and hemorrhagic hypovolemia to what I'm going to call arterial hypovolemia. That's all the other forms of shock, actually. Arterial hypovolemia means you might have volume, but it's in the wrong space. It's in the wrong space because you got a bad heart. When you have cardiogenic failure, a heart failure, you have volume, it's in the veins, it's in the interstitium, but it never gets to the arteries because you have pump failure. So your pump's not functioning normally, so you have reduction in forward flow. Obstructive shock is typically obstruction, most particularly in the pulmonary bed. That's really oftentimes related to a pulmonary embolism. It may also be related to positive pressure breathing. You have primary or secondary right heart failure, and you have an obstruction in the pulmonary vault that limits your blood flow. The other obstruction that can occur is when you have something taking up space in the thoracic cage, like air with a pneumothorax or a hemothorax, which then compresses the aorta and obstructs the outflow from the left ventricle. That's something's in the, not the something's in the way of the blood flow. And then, of course, is vasodilation or distributive shock, where your patient has lost vascular tone and they cannot maintain an arterial pressure, which then further reduces the blood flow dynamic and the blood that's flowing back to the right heart. So really, really critically and profoundly important. Really, really important to appreciate vasodilation, which can occur from hyperinflammation, which is exacerbated by metabolic acidosis, and which can be a loss of control at the actual surface of the vessel through the expression from the vessel of local mediators that promote vasodilation. So 4 main types of shock: hypovolemic, cardiogenic, obstructive, and vasodilation or distributive shock. Those shocks all have subsets. There's not just, here they are, now you know them, everything's right with the world, no problem ever again in kind of intervening or evaluating patients. Okay, so what is shock? Always remember, shock is actually about inadequate perfusion. And it's a shift because you're hypoperfused to anaerobic metabolism, which will be signified to you by the high presence of metabolic acid. The subset of that could be lactic acid. The high presence of metabolic acid, which is typically evaluated by the consumption of acid neutralizer, bicarbonate, or circulating base. So when bicarb is low or base is in deficit, we're going to assume metabolic acidosis. Now, eventually, what's going to happen is you're going to have profound alteration in the capillary integrity and the cellular integrity, where you actually have fluid fluxing now out into the interstitium and fluid moving into the cell, causing cellular edema and cellular rupture, a complete and utter loss of vascular tone, and a complete and utter loss of perfusion at the tissue level. Now, as we look at this patient, I want you to pay particular attention to his worsening acidosis. And in particular, we look at the primary four causes of metabolic acidosis in critically ill patients. Number 1, AKI. Number 2, DKA. Number 3, the presence of an inadequate buffer, that would be chloride, so high chloride. And number 4, lactic acidosis. 4 most common reasons for metabolic acidosis in the ICU: AKI, DKA, high chloride, which is an inadequate buffer and it replaces bicarbonate, and lactic acidosis. So when you're at the bedside, you're always considering the presence of those abnormalities that may affect your ability to maintain your vascular tone and the ability for you to maintain your perfusion. Okay, so I always use this little simple cartoon. It actually is my cartoon and it's in publication. It's available all over the place, to just remind you that the purpose of the lung is to oxygenate your blood. Oxygenated blood returns via the pulmonary veins to the left atrial, left ventricle, and is ejected out into the systemic artery. And when we look at the systemic artery, we look at the hemoglobin and the saturation, the hemoglobin in the arterial bed, that's your SaO2. And of course, normal SaO2 is 90 to 100% of the hemoglobin is saturated. Now that blood actually driven by your mean arterial pressure and the pressure gradient from the mean arterial pressure to the central venous pressure, MAP minus CVP. If you have a CVP, that gradient, MAP minus CVP, tells us about how well we are able to actually push the blood through the capillaries where oxygen is released in order to be used by the cell. So number one, you must have good capillary blood flow in order for the cells to be oxygenated. Now, you can't really look at capillary blood flow, but you evaluate that by whether or not you have oxygen bound to the hemoglobin when measured in the central vein, okay? And that's really what we're talking about today is the central vein. If I draw a sample from your central vein, not peripheral, central vein. I draw a sample from the central vein. I send it to the blood gas lab. I'm going to look first and foremost at the saturation of hemoglobin in the central vein. Okay. If that saturation of hemoglobin in the central vein is low, that typically means you have good capillary flow. If this, and what that means is I have to support the blood flow dynamic. I have to improve your oxygen delivery, give you a better stroke volume. I might give you hemoglobin. I might try to attain a better arterial saturation. I'm going to treat those three things. I also want to diminish the amount of oxygen the cells are demanding by using sedation, analgesia, temperature control, and if necessary, paralytic agents in order to control the cellular consumption of oxygen. When SCVO2 is low, you are flowing the blood and the cells are using oxygen, and it means they're using too much or you're not delivering enough. So by the way, when I see a low SVO2, I'm pretty happy because I think I can treat it, but I have to treat it quickly. I have to treat it aggressively because for every SCVO2 that's less than 60%, I'm putting your cells at risk. Okay, so that's a really important concept when I'm thinking about my patient. Now, we think about stages of shock. This is always a progressive process. First stage of shock, the patient's compensated. They have normally an increase in their heart rate and or an increase in their stroke volume in order to deliver more oxygen. And they may also have enhanced vascular tone to maintain a blood pressure within normal. So when I approach the bedside of the patient, what I expect to see is that they're going to have an increased heart rate. They may also have an increased respiratory rate. So tachycardia and tachypnea are my first signs, okay? Now, in all shocks except for distributive shock, my expectation is the extremities are going to be cold. Might be hard for me to get a pulse ox. You're cold. The coloration may be cyanotic. And if you have sepsis, I'm going to expect that the hands and feet are warm and that the pulse is really strong. But I need laboratory analysis to help me uncover compensated shock. I can't really just make that evaluation clinically. As patients progress, they start to decompensate. Decompensation is when patients present with hypotension. They are decompensated. They can't increase their cardiac output to maintain their blood pressure, and their regulation of the vascular tone is inadequate to maintain their blood pressure. So I treat two things. I treat your cardiac output and I treat your vascular tone. That's what you do every day at the bedside. You give patients volume and then you give them a vasopressor. You are treating them because they are either on the edge of decompensation or they have already decompensated and they're hypotensive. But we move forward from that to irreversible shock. When we haven't intervened at the first stage and or the second stage, or our intervention isn't working, our patients move forward into the third stage, which is irreversible organ damage, which typically ends in cardiac arrest and typically death. This is not reversible in general. So our goal is to recognize you here and here in the first stage and the second stage, treat you effectively in first stage and second stage. And we're going to think about the things that we really want to use to help us monitor perfusion. Okay. So first of all, just bedside, I'm looking for an increased heart rate if you're able to manifest that. If you're on beta block therapy, if you have an infarcted sinus node, you've had an inferior MI, I might not even know that about you. I might not know anything about you when I first see you, but I expect if you are in a compensated form of shock, that your heart rate will be up, that your respiratory rate will be up, and that you have a pulse pressure, systole minus diastole, that is normal to mildly elevated. So normal pulse pressure is 30 to 40. A little bit elevated is what I typically will see with somebody who has distributive shock. Diminished pulse pressure typically means that you have some kind of arterial hypovolemia. Okay, well, that could be pure hypovolemia, that could be cardiogenic shock, that could be obstructive shock. Don't know what it is, just know that your pulse pressure is narrow. And then I'm going to look for some subtle changes in level of consciousness. Well, if I don't know you, I don't know what your level of consciousness normally is, but you might seem a little bit disorganized, a little bit disoriented. You might even be a little delirious. Okay, those are the clinical things. I'm going to look at capillary refill, pulses, skin color, skin temperature, all those perspectives that I'm going to use at the bedside to just evaluate, do you have good blood flow? Okay, are you well perfused? From my laboratory analysis, the primary things I'm going to look at is your total serum CO2 on your chemistry. Total serum CO2 gives rise to bicarb. So those are basically the same measures. When I look at, and I'm going to just remind everyone who's just joined, please mute yourself, my friends. Make sure you mute yourself, my friends, when you join a call. Thank you so much. So bicarb down, total serum CO2 on your chemistry, or you might see on your chemistry, depending on where you work, that it's bicarb. Here at Grady, we call it total serum CO2. That's going to be down. That means your metabolic acid is up. Typically, we expect that your anion gap will be wide, wider than 20. That's the difference between positive ions and negative ions. Metabolic acid being an unseen positive, creating that gap. Your potassium, typically with metabolic acidosis, your potassium will be elevated. It's going to be a little hard to differentiate that if you've also got acute kidney injury or chronic kidney disease. If I have a normal potassium and chronic kidney disease, I've really got some problems. So that's really important for us to recognize. Love to do an ABG plus a VBG, but if all I've got is I've got a central line, I'm going to do a central line VBG. If I don't have anything, I can do a peripheral gas, but a peripheral gas is not going to have very much meaning except at the level of the base deficit and the pH. The oxygen levels aren't going to matter. The CO2 level isn't going to matter in a VBG. The only thing, standard VBG, that I'm going to use to identify where my patient is their base deficit and their serum pH. And of course, I love to draw lactic acid. I hang my hat on it. It isn't actually all that meaningful because it can be normal and I can have a patient who's very shocky, or it can be very elevated in a patient who isn't shocky. So it is important to always look at lactic acid with just some seeds of concern in discussion about what that lactic acid level actually means for your patient. So we just remember hypovolemic shock means total blood volume is down. You see that with hemorrhage, burns, diarrhea, excessive perspiration. Fix the cause, replace the volume, and support the blood pressure if necessary. With cardiogenic shock, that's the inability of the muscle to adequately eject volume. And typically that comes because you have heart failure, you have dysrhythm, you have a valvular deficit, you have an MI, either old or new, you have tachycardia, you have bradycardia, all those different causes. And what we want to do is, if we can fix the underlying cause, like if you have acute coronary syndrome, we'll try to fix that. And we will also stimulate your cardiac muscle with a positive inotrope. We're always going to want to optimize fluid and blood pressure. Vasodilation or distributive shock causes are hyperinflammation from sepsis, severe profound metabolic acidosis, spinal cord injury, anaphylaxis. Fix the cause, give volume, give vasopressors. Pretty straightforward when we think about shock. And by the way, sometimes when you have shock, you need a PA catheter, because all forms of shock ultimately are going to be hypotensive and they're all going to be acidotic. So looking at hypotension and looking at the presence of metabolic acid does not help you to differentiate shock. What's going to really help you differentiate shock is a pulmonary arterial catheter. So just as a side approach, really important. So let's talk about our patient. This is our patient's admission note and his first set of vitals. He's admitted to a medical surgical floor directly from an out-of-system hospital. So not Grady, not through the ED, a direct admit to a medical surgical floor at our hospital. He's an 80-year-old man who has had a ground level fall, and he has sustained with his ground level fall, which tells you he's got pretty brittle bones, right? He's had a thoracic spinal fracture. He must have surgery, and the out-of-system hospital says we can't actually perform surgery with bloodless surgery, which is what that's called. When you have a Jehovah's Witness, you're going to agree to do surgery without blood replacement. And that's a special certification. It's a specialized practice. So either they are unable or unwilling to do the surgery on this patient because they believe that postoperatively he will most likely need bloodless management, that's a specialty, and an ICU care. And they apparently didn't either have an ICU, or they were not able or willing or not certified to do bloodless surgery. I did not investigate. I know what hospital system transferred him, but I didn't investigate the full reason. So he is transferred directly to us. Our surgical team accepts him. They move him directly onto a medical surgical floor, not a tele floor, not an ICU. And he arrives, or at least he may have arrived at a different time, but his first set of vital signs, his heart rate is 50 and his blood pressure is 86/66. Now, our assumption will always be here that he has hypotension because he has bradycardia. We don't know which one came first. We don't know because we don't know the patient. We don't know what else happened. But whenever you're hypotensive, you should always be tachycardic. Always, always, always. When you're hypotensive, you should be tachycardic. That's the normal physiologic response to sympathetic stimulation, circulating neurotransmitters. So our expectation is if you're hypotensive, you should be tachycardic. He's both bradycardic and hypotensive. Okay, well, whoever looked at him was very concerned. They notified everybody. Everybody got on board. Everyone is concerned about the patient. They look at his respirations, his MAP. I don't have a pulse ox at that time, and I have an oral temperature on this patient. Okay, so first and foremost, we're on a med surg floor. They did a fantastic job. They identified that patient pretty well. We can all say that we would never want to really do an oral temp because oral temps are uniquely unreliable. So, of course, we don't really want to do oral temps on patients. I'm not positive, although probably it was an oral temperature with a little slide doing an oral temp instead of a scan of the forehead or the ear scanner. But just remember, oral temperatures are pretty unreliable and wouldn't have made any difference in the case, but probably his temperature was not that. This is his first EKG at 5:24 a.m. So I'm asking you what you think. I don't want you to unmute. I just want you to think. I want you to look at this. I want you to remember you're looking at EKG leads 1, 2, 3, AVR, AVL, AVF, V1, 2, and 3, V4, 5, and 6. And down here, you're looking at a rhythm strip. So these are just short blippets, 3 seconds of time. This is a total of 9 seconds of time, the rhythm strip. When I'm looking at that rhythm strip, I don't feel myself that I can make a case that the patient has any P wave or any atrial activity. I wouldn't call this atrial fib. I would call this idioventricular rhythm. Idioventricular, meaning that I have an impulse in the ventricle that's firing, capturing the ventricular myocardium, promoting a ventricular contraction, but it's inadequate to maintain my blood flow because I can see I don't have labs yet. I can see that my blood pressure is low. So I have idioventricular rhythm with hypotension. Okay, so this actually, from my point of view, would be considered at this moment a form of cardiogenic shock. It's rhythm-induced cardiogenic shock. Now, the patient's heart rate actually goes down into the 30s. He never loses his pulse, but he has a heart rate of 30 and he's profoundly hypotensive. That's what ultimately happens or is happening at this time. But here's the only EKG that I have. In addition to that, you might say, oh, look, Barbara, he has ST segment elevation in V1, V2, and V3. Really doesn't have any V4. Typically, we see that that ST segment elevation. Now, remember, he's got idioventricular rhythm, so pretty much all bets are off because this isn't even a normal rhythm. But oftentimes, we're going to see ST segment elevation in V1, V2, and V3 because we have evidence of a left bundle branch block. Now, if I look at lead 1 and I look at AVL, I can see that they both are pointing upright, which means the current is primarily going to the left. That's why they're pointing upright. If the current was going away from the left, they point downward. Pointing upright, I have an R wave, and that R wave is taking time to occur. So it's wide and it's upright in lead 1 and AVL. This is consistent with the left bundle branch block. In addition to that, I have a T wave inversion, which is also consistent with a left bundle branch block. Now, we don't know the patient, right? So when I'm looking at this, I'm like, oh my gosh, I believe this patient's in cardiogenic shock. He has a left bundle branch block. He's an IVR. I'm very concerned about him because A, he's in idioventricular rhythm, which means that he has, at this point, may have some level of complete heart block. I'm very concerned about that. And I'm very concerned that he has a left bundle branch block. I don't know if it's new or old because I don't know the patient. For me, the very first thing I would do, and I think what I would say is I think the first thing that they did is that I would probably, well, similar. I would probably not waste any time on atropine. I would give epinephrine. And if my patient responds to epinephrine, Yahoo. And if he doesn't respond to epinephrine, I'm going to do transcutaneous pacing because I think he's got complete heart block. If I give him epinephrine, I might increase his idioventricular rate, but I may not actually restore communication from atria to ventricle, which means my patient's at risk for asystole. Okay, so I can't tell you everything they did because the notes are pretty sparse. There's a lot of description, and the description from different attendings and different APPs sometimes is a little different, and there's nothing in nursing that tells me what nurses did. I know they were busy. I know they did a fantastic job because they got everybody to the bedside. They saved the patient's life, but there's not documentation. So I can't really tell you what happened in that relationship. I can tell you what medications he got. He did get atropine. He did get epinephrine. He got some other agents. And they said, let's get him as soon as possible to the ICU. So this is 554. So after that first EKG, 524, we now have his first set of vitals, or at least of his blood pressure when he gets into the ICU. Now, this is the way it's read on Epic. So on the floor, they call to code blue while the patient's on med surg. Trauma team says, okay, we are going to sign off our trauma team for med surg. We're not going to take care of the patient. We got to transfer that patient to the ICU. He has symptomatic bradycardia. Remember, I said his heart rate went down to somewhere around 30. He's hypotensive, never lost his pulse, got atropine, epinephrine, sodium bicarb, transferred to the ICU, emergently received a central line and an arterial line, started on norepinephrine and epinephrine. New labs and imaging are all pending. He gets some volume. He gets bicarb, he gets epi, he gets norepi, he gets calcium. Every tick is checked. Everything that we should do. Volume in case he is hypovolemic and hypovolemic shock. Volume in case he's septic. Epinephrine, norepinephrine to restore his vascular tone. Calcium, because if he's hypocalcemic, which he could be, he's an 80-year-old. He has chronic kidney disease. He could be hypocalcemic. We gave him some calcium, and ultimately the blood pressure response. So this is 554, 6 minutes later, you can see his blood pressure comes up. His heart rate here is 81. Okay, phew, saved his life, saved his life. This time, many times, saved his life, saved his life, saved his life. Phew, okay. So now we look at his just some basic things. I'm not telling you I've got all the evidence. Everything isn't in the chart. I can't find everything in the chart, but what I see, this is at 624 on 421. So he's already in the ICU. First of all, we see the plasma pH, 7.036. Okay, he's got significant, profound acidosis. We're not sure yet. We will be in a second. We're not sure yet what kind of acidosis he has. Remember, with metabolic acidosis, the metabolic acid, hydrogen ion, displaces your potassium and is a non-depolarizing ion. So when you have severe metabolic acidosis, my friends, you will always have refractory hypotension. When you have severe metabolic acidosis, you will always have severe refractory hypotension. So now we go down and we look at his lactic acid level, 14. His HS troponin, 10. A lactic acid level of 14. He has chronic kidney disease. He has a lactic acid level of 14. I don't have anything else quite yet. I'm going to have it in a minute, but right away, I've got a pH of 7.036 and a lactic acid level of 14. Okay, well, I still don't know much about the patient. I think he's got some level of cardiogenic shock because of his dysrhythmia, but now I'm also going to say, oh, I think he may also have septic shock. I think that he might have more than one thing happening right now. In fact, he may have hypovolemic shock, septic shock, and cardiogenic shock all at the same time, but I don't really know. And gee, maybe he's also had a PE. Don't really know. I'm winging it. I'm basically treating this patient in the ICU, but he really is like an emergency room patient because I don't know anything about him. So I'm doing the best I can and gathering all the data, and a great job was done by all. Okay. So, wow, that pH 7.036, no wonder the patient's hypotensive. And then, wow, times 2, look at his lactic acid level and look at his HS troponin. HS troponin is high sensitivity. We always expect that in a male to be less than 20. He's 10,746. Now, when I'm looking at your HS troponin, the first question I'm asking is, did you all do CPR? Did you defibrillate him? No, of course they didn't defibrillate him. They didn't need to. He had IVR, idioventricular rhythm. He didn't have VFib. He didn't have VTAC. He didn't get defibrillated. So I'm thinking, okay, this is concerning about your myocardium. Have you lost myocardial tissue? Is there the possibility that you've had a myocardial infarction, which then would also lead me to think you've got cardiogenic shock? This is all the information we have. And we have a chest x-ray. Now, just looking at that chest x-ray, you can see that you've got this really, really big fluid shadow here. There's a huge fluid shadow here. This looks like your cardiac silhouette, but you've got this big shadow. So is that, I'm not a radiologist. I'm looking at this. I have some concern about the size of your myocardium. And by the way, I've got a little concern about this as well. This is your aorta. And is this just because of your injury? Is that why I'm seeing this? So look at that deviation. That I'm assuming that's from the thoracic spinal injury, but I'm a little bit worried about the diameter, the size here of the aorta, and what I believe to be the size of the heart. I'm not sure. I would have to have somebody much more expert than me when I'm looking at that chest x-ray. And of course, most of us aren't looking at the chest x-ray. If we're lucky, we're reading the radiologist report or hearing back from our provider what was seen on that chest x-ray. So quite important for us when we're thinking about our patient. Then we look at his labs starting to roll in, okay? So his white count is 15.3. Uh-oh, I think he's septic. Hemoglobin is 10.2. We don't generally get too alarmed about that. It's not really that big of a problem, right? No diff is done because apparently they didn't feel the need to do a diff until much later, until 5 p.m. on 4/22. However, based on that white count, broad spectrum antibiotics are begun. Pulse Vanco started cefazolin, I think, but also vancomycin. So broad spectrum antibiotics are started with a concern that the patient has chronic kidney disease. So pharmacy is all over it. They start that, looking at the fact that the patient looks like he's also septic with a cardiac component. Now, here's the question. Was he septic, and is that why he fell? We don't know that. All we know is he had a ground level fall. He had a thoracic spinal injury, had a compression injury. We don't know why he fell. We don't know. Did you fall because you had a cardiac event? Did you fall because you have sepsis? You have a gross UTI? What's your problem? Doesn't look like the problem is in the lung, but you look septic. We don't know you. Again, this is for somebody in an ICU, this is really difficult because this patient is like an emergency room patient. We know nothing about you. We're gathering all these points of data, trying to come to a conclusion. Usually by the time a patient comes to the ICU, at least some conclusions have already been made. This patient is like an ER patient. He goes to med surg, he almost immediately goes to the ICU. We really don't know much about him. We have a good family, we have a good history, but we really don't know very much about what's happening. But the patient is definitely hypoperfused because he has a very elevated lactic acid level. And we're going to find out some other things that actually contribute to his lactic acidosis in a few minutes. But also, we're looking at the fact that the patient has bradycardia and hypotension. He has idioventricular rhythm. He's a mess, and he's 80. He's kind of a mess. And we're trying to do the best we can to keep him alive. And a good job was done by all, by the way. Okay. Second EKG, 642 in the ICU. Now, I am now starting to see just a tad bit of variability, although I still would probably consider that this is, from my point of view, it doesn't make it right. Just looking at the EKG, I would probably consider this to be indicative of accelerated idioventricular rhythm. I still think it's idioventricular. He still has that left bundle branch block, ST segment elevation V1 through V3, where it's pretty acute. You have a little tiny bit in V4. That's usually indicative of left ventricular hypertrophy or left bundle branch block. He definitely has a left bundle branch block. Don't know if it's new or old. I don't have an old EKG. Can't compare it. Just working on what I'm seeing. And I'm calling this myself an accelerated idioventricular rhythm. Now, the computer calls it atrial fibrillation. So I have a feeling that probably everybody said, oh yeah, it's atrial fibrillation. Okay. Does he have a history of AFib? Is this new onset AFib? New onset AFib occurs frequently when you have a pulmonary embolism. So again, that's something else to be thinking about. Maybe that's why he fell. Maybe he lost consciousness and then he fell to the ground. We don't know. So we're having to think about all these things in evaluation of the patient. And thank goodness we have a great abundance of fabulous APPs and attending physicians, all of whom are focused on what's happening with this patient. 627, I get another venous gas, pH is 7.07. Base deficit, -12. Okay. Patient is profoundly acidotic, but not only does he have metabolic acidosis, he also has respiratory acidosis. Okay. Now, let me say this. He might not have respiratory acidosis. This actually might be indicative that he's got a low cardiac output. So all my friends, I hope there's quite a few here from the ICU where this patient went, because what I want you to do is compare your venous sample and your arterial sample. Okay. So you can see you're very acidotic with your pH here, a little less acidotic in the arterial sample because you actually are blowing off CO2. This is not what you think of respiratory acidosis, which is ventilation acidosis. This is tissue production, respiratory acid. Your CO2 here and your dissolved oxygen in your venous sample. So dissolved oxygen in your venous sample should be 45 to 55. Anything that's below 36 in terms of venous oxygen means one thing, and that is you have inadequate cardiac output. Okay, so I should be all over this patient, and they were giving inotrope, being aware that we needed vasopressor activity because he has got hypotension, but he needs inotrope and he needs it fast because his PVO2 should be 45 to 55 and it's 20. Anything less than 36 or 37, 1 point, doesn't matter, just different literature, says that your patient has inadequate cardiac output. He's producing a lot of carbon dioxide, which is the byproduct of anaerobic metabolism in the venous bed, but he is clearing it through his ventilation. And his lungs look pretty good on the chest x-ray, so I don't really think he's got a primary lung function. He's just got to blow off all that CO2, and we need for him to actually blow off more CO2 in order to compensate for his profound metabolic acidosis. Now he's got profound metabolic acidosis and a high level of lactic acid, but you're looking at this patient who has chronic kidney disease and he's 80 years old. You should have some other questions. His lactic acid level is elevated. Is that just tissue hyperperfusion, or could it also be congruent or concurrent with his acute kidney disease because or his chronic kidney disease because the kidney helps to clear lactate? And does he actually have liver disease because the liver actually helps you clear lactate? So the very first thing we think about when we see these blood gases is, and we saw that lactic acid level of 14, what else do I need to evaluate to make sure that my docs and my APPs have all the information that they need? And what should I be asking for? What should I be, maybe I'm not asking for it, but I'm anticipating that I'm going to do a liver profile, that I'm going to do some other things that really tell me about how to narrow down the diagnosis of this patient who we really have no idea what actually happened. Why did he fall? Did he lose consciousness? Is he septic? Does he have cardiogenic failure? And we're building our case as we go along. Our first step, though, is this comparative analysis of the arterial and the venous sample. Okay, now remember, he's gotten a central line. So this is a central venous sample. Okay, and he has an arterial line. So this is a good sample. And you can see we drew them, I think, at the same time. They got like delivered back to us a few minutes apart, but they were drawn at the same time. I'm positive, knowing how great this ICU is, that they were done at the same time. So I'm looking now at my oxyhemoglobin. It's 96% in the arterial bed, and my venous oxyhemoglobin here is 19%. Okay, well, I could have told you at least generally that his SpO2 would be low because his PVO2 is low, because his tissues are using an extraordinary amount of oxygen because he is not delivering adequate blood flow. Now, normally when you're not delivering adequate blood flow and you're this bad, my number one thing is I'm going to give you inotrope. I'm going to increase your stroke volume, and I'm going to do that right away. I'm not waiting 4 hours, 6 hours, 8 hours. I don't need cardiology to come. I'm the person looking at this patient. He has inadequate blood flow. He needs an inotrope. He might need volume. We don't know. He's got chronic kidney disease, so we're going to be a little hesitant. I'm going to give him an inotrope. Probably going to give him some vasopressor. I'm going to be very careful with the titration of vasopressor because I don't want to limit cardiac ejection, but he definitely needs an inotrope. Probably really need to consider that he might need more calcium. I also might need to try to neutralize his metabolic acid, at least for the short term, with bicarbonate, all of which they did. I don't know that they were done right then, but during the day, he got all these different items of intervention. Very fantastic job. But me as the bedside nurse, when I see this, I'm like all over everybody. He has a very inadequate blood flow dynamic. He is using so much oxygen from his venous reservoir. His PVO2 is 20. His SVO2 is 19%. This is linked significantly with about 95% mortality. So I'm going to be all over this immediately as soon as possible. And I think everybody was. Don't really need to worry too much about whether or not he needs blood. His hemoglobin is 11.2. I'm not going to give him blood. The blood bank's not going to give me blood. He's got a hemoglobin. I mean, even if he wasn't a Jehovah's Witness, doesn't matter. His hemoglobin's 11.2. He doesn't need blood right now. What he needs is increased stroke volume and cardiac output. And he can't manifest it himself because he can't increase his heart rate. And by the way, he still looks like his idioventricular rhythm, which means he's lost the component of atrial contraction. If I could do anything, I would give him an AV sequential pacer. That's what I'd want to do. But I can't do that. I can't do that on this patient. He's not going to have his chest cracked, and he's not going right now to the cardiac cath lab. We're not going to give him an AV sequential pacer. The only kind of pacing we could do for him right now would be transcutaneous or transvenous. And I don't think anybody wanted to do that, and I support that decision mightily. Okay. So he's gotten epi, he's on epinephrine, he's on norepinephrine. This is his next EKG. This is at 9:50 a.m. on 4/21. Okay, still got a left bundle branch block. Now he's just got a much more rapid rhythm. And again, the computer says patient's an AFib. I'm not positive he's an AFib. It's okay. If he's an AFib or is an IVR, you know what? He's lost the component of atrial contraction to fill the ventricle. I don't really care. If it's IVR or AFib, he's lost probably 20 to 30% of his ventricular filling volume, because if his atria is doing this, it's not contracting normally and pushing blood down into the ventricle. Or if he's got IVR, now it would be AIVR, accelerated idioventricular rhythm, he's lost the atrial kick or the atrial contraction. So his cardiac output is low. I still feel like he's in rhythm related. That's the only thing I could say at this point. Rhythm related cardiogenic shock. That's what I think. Okay. I have the benefit of looking at all the labs, looking at the EKGs, thinking, processing. Nobody's life is on my fingertips. I'm not trying to keep the patient alive and do everything else I need to do. I'm just looking at the information and sharing with you what my perspective is in a retrospective manner, and I wasn't at the bedside. Okay. At 9:58, this is the way these are listed because I think they must have either done something to control the rate or the time was listed incorrectly on the EKGs. This is what we see at 9:58. Okay, still in a left bundle branch block. Now we have these other beats that are in between, are kind of our normal rhythm beats. I'm still not sure whether he's an AFib or idioventricular rhythm. Not really sure. Don't really I'm not really in terms of end effect. I'm not really worried about whether it's AFib or IVR. It's new onset and it significantly reduces his ventricular filling volume. I want to control whatever this is. If it's AFib, I want to control it. If it's idioventricular rhythm, I want to pace him. So I do need to have communication. Somebody needs to have communication. I'm sure everybody was talking about it, about what's next. Is this actually AFib? How do we control the AFib? And I think the decision was that he is an AFib because they start on amiodarone. Okay, now I want to remind everybody, amiodarone is a miracle agent. It blocks the uptake of potassium, which then also means that the co-transport calcium gets blocked. If I block the uptake of potassium and the uptake of calcium, which is secondary, amiodarone is a potassium channel antagonist, blocks the uptake of potassium. Potassium works as a co-transport for calcium. Calcium is necessary for myocardial contraction. Calcium is necessary for vascular tone. What I can see when I'm administering amiodarone is that my refractory hypotension might get a little bit worse. Now, I can treat that by giving you some calcium, and I can give you some calcium, and he got calcium. I think he got calcium all day long. Everybody was doing a great job yet again, but I just want you to remember when you give amiodarone, you oftentimes will have a secondary effect of hypotension because you've blocked the uptake of potassium and therefore calcium at the vascular level, and now you've lost some vascular tone. Okay, so now we just go on and continue looking at his blood gases, okay? So I think he did not get, it sounded like he got intubated on the evening of 4/21, sounded that way. I'm not positive, but you can see it's okay. He does get significant improvements. So either that is with high flow oxygen or BiPAP or something else. He does have some significant improvement, right? And you can see his PO2 is looking pretty good, still acidotic, still has a severe significant base deficit, right? But now he's also blowing off more CO2, so that brings his pH up just a tiny bit. Not that much, just a tiny bit. And his base deficit gets worse again at 4/21. So now if he is not intubated, and he has control of his own ventilation, or he's intubated and he's on assist control, he's breathing a little bit faster. He's mobilizing more CO2 to try to compensate for his very, very significant and profound metabolic acidosis. Now we take a look at his chemistry. Here's his first chemistry. This is the result. So it's not really when it was drawn. I think this is when it was resulted. So we just take a look at this. Now remember, he's got chronic kidney disease. I would have expected much higher potassium. His potassium is 4.5. But what I'm really concerned about when I'm looking at this is the fact that, first and foremost, he's hyperglycemic. Okay, so he gets placed on insulin. He gets placed on an insulin drip because his glucose is extraordinarily high. By the time I would have assumed, and perhaps it was there and I just didn't see it, that he had a point of care glucose. Any glucose greater than 180, I'm going to repeat in an hour. If it's greater than 180, again, you need to start on insulin. You're critically ill. Remember, the glucose in the serum is not glucose in the cell, and this is going to put an extraordinary burden on the myocardium and an extraordinary burden on the brain. So I do not want to let somebody this unstable. I know a lot of times people are like, well, I'm more worried about his blood pressure right now. No, you got to worry about his blood pressure and you got to worry about his hyperglycemia. You got to put him on insulin immediately. He did get put on insulin very quickly. I'm not positive what the timing is, but he did get put on an insulin drip. But you can see here, his glucose goes from here at 1124, 246 to 398. So now we're bordering on the edge of, because he has the history of diabetes, we're bordering on the edge of the possibility for, and we could have been already in ketosis. So don't know that for sure at this moment in time, but I do want to remind you that we also had to be concerned, did he actually have liver dysfunction? So now I'm going to go down, I'm going to take a look at 1855 on 421. We see that these enzymes start to go up. Okay, we don't have an ammonia level because that wasn't ordered. We don't have a beta hydroxy because that wasn't ordered. But got to think about, should I have that? My glucose is 398. Do I need beta hydroxy? Yes. Okay. Usually I would say no, because you're going to look at the anion gap. The anion gap is kind of a mess. Look at his anion gap, 34. Any anion gap greater than 20 tells you you've got severe profound acidosis. You have AKI, you have CKD, and you have AKI, acute kidney injury on top of CKD. Probably have some liver failure. You have hypoperfusion. You're a mess. You come to the hospital already a mess. Thank God you were here when you became hypotensive and bradycardic so we could jump all over you and do everything that we could do. He's quite a mess. His bicarb is 11. His anion gap is 34. His bicarb is 17, his anion gap is 23. Between 1124 and 1855, this patient got significantly worse. Sometimes that happens because the natural pathology of your disease just progresses, no matter what we do. Sometimes it happens because we're so intent on getting your blood pressure up, we actually can cause significant more issues with our vasopressors if we're not also paying attention to your stroke volume. Again, I'm not saying that's what happened in this case. I'm just saying you need to be aware that in your dutiful pursuit of blood pressure, sometimes you can make things worse. Epinephrine, norepinephrine make you insulin resistant. Epinephrine, norepinephrine can cause profound ischemic burden to the myocardium. So we always need to be considering that, particularly in a patient where we're not certain about what's occurring. And we're going to follow you religiously to see, does your acidosis get better or worse? If your acidosis is getting worse, vasopressors may be contributing to that. And that's just something that we're going to think about. Okay, now we go down to his lactic acid. Remember, before it was 14.2, now it's 15.5. And of course, his HS troponin also very, very elevated. Whoa, man, you got a really wide anion gap. It's 34. You got a really low bicarb. It's 11. Chloride's not your problem. This is ketosis, lactic acidosis, kidney injury, maybe something else. It's probably from liver failure. There are a lot of things here that are contributing to your acidosis. It's never as easy as 1, 2, 3. If it was that easy, everybody would survive. It's not that easy. This patient is really sick. But I also want to bring you to his calcium levels, which are low. Now, remember, when we talk about calcium, calcium is unbound, free to use. That's the ionized calcium, and bound, and that's usually bound to albumin. That's why our labs give us an adjusted calcium albumin. But so when you're hypoalbuminemic, this may be normal, but it's quite low. So again, this is a patient who did receive calcium, who really needs calcium. Calcium can restore some of your vascular tone. Calcium can restore your myocardial contractility. First echo occurs on 421, okay? First echo, LV is normal. LV function is a little bit reduced, but the LV is normal in its size, and your ejection fraction is 40%. Okay, that's your first echo on 421. So you're in the ICU, you get an echo, it's 40%. Now, normal is 50 to 75, but right away, when we're looking at that, we're saying, oh, look, this isn't cardiogenic shock. He has a normal ejection fraction. Yeah, but if you're only ejecting 30 or 40 or 50 times a minute, you could still be in cardiogenic shock because of your rhythm, not because of loss of myocardium, but because your heart rate isn't compensating. right? So remember that he had that low heart rate. He had it for a while. He didn't compensate by increasing his heart rate. So even though the ejection fraction is 40%, meaning 40% of what filled the ventricle gets ejected, it's not happening at a regular basis. So it could be rhythm-related cardiogenic shock. And of course, he looks septic, so we think he's got septic shock. He may have other problems. We look at the right ventricle here. They couldn't see it very well, but the right ventricle is mildly dilated, and the right ventricular ejection is mildly reduced. So don't really know, does he have some right ventricular failure? Why would he have right ventricular failure? Is he a smoker? Does he have pulmonary hypertension? Did he have a small pulmonary embolism? We don't know. We don't know that. We're still trying to figure out what the heck's going on. His EF is okay, but it's not great. What I want you to remember, though, is your EF changes. So just because you had an EF that was 40% today doesn't mean it's going to be 40% tomorrow. And of course, we completely appreciate that if we're talking about acute coronary syndrome and myocardial infarction. But my friends, when you're septic, you also release something called myocardial depressant factor. So that MDF in circulation causes your EF to go down. So just because you're okay today doesn't mean that you're going to be okay tomorrow. And everybody at the bedside knew that because they got another echo on that next day. But today's echo, 421, so this was just a few days ago, 40%. Okay, here's this 50 kg, 2240 on 421. Now, this is the last one that I see posted. I'm positive it's not the last one that was done, but it's the last one that got loaded. And again, what we're going to see here is the same thing that we've seen all along, is this wide QRS, left bundle branch block, intermittent early depolarizations, probably PACs, might be AFib, might still be IVR. I think everybody had determined it was AFib. They started the patient on amiodarone, but that never really changed much. So again, I would always just want to come back and say, do we think this might be idioventricular rhythm? Is that a possibility? Because I'm not really seeing atrial activity here. Okay, again, in the end, it doesn't really matter. What I've lost is atrial kick. What I've lost is atrial kick. So I have a significant reduction in the filling volume of the ventricle, and therefore the overall ejection. 40% of 100 is not the same as 40% of 300. So he may have low ventricular filling because he doesn't have an atrial contraction, and he may eject 40% of what filled the ventricle, but if what filled the ventricle is low, that still is inadequate, and it still is a basic shock presentation. Okay, so as we go on, we're looking at his blood gases, and I think right around here is where the EPP said that he was emergently intubated, right around here, okay? But again, I'm kind of looking at the notes and they're kind of all over the place. I'm uncertain exactly what happened, and I didn't get to read all of the notes before the time of this talk. But somewhere right around here, he gets emergently intubated, okay? And you can see that now we're blowing off his CO2. He's very well oxygenated. His lungs look good. And for the first time, his base deficit is less than 11. Okay, very nice. And his PVO2 is normal. In fact, it's a little bit high by the lab. His pH for the first time is above 7.15. Yahoo! We're feeling pretty good about how he looks right now, but mostly that's occurred because we've intubated him. We're helping him blow off CO2. Don't know that necessarily at the tissue level, his perfusion is any better. Probably isn't. Probably still pretty significantly poor. Okay, well, I say here, that when we looked at right before intubation, you can see he has a very, very profound base deficit, a very significant low pH. He's lost his vascular tone. Everybody at the bedside is titrating up on epinephrine, norepinephrine. He's on vasopressin, trying to get his blood pressure up, start him on dopamine. He's on dobutamine. Can't really get him under control, but mostly it's correlated to the fact that he has this profound metabolic acidosis. Don't ask me if they gave him bicarb. Of course they gave him bicarb. Did they actually put in an emergent vas cath to start CRT? Yes, these are fantastic providers. And by the way, the intensivist on call that week is an intensivist plus a nephrologist. I guarantee you, he's going to put in a vas cath. He's going to ask for a vas cath and get a patient on CRT with this kind of picture. He's got CKD, AKI, and he has refractory metabolic acidosis. Yes, he got bicarb. Yes, he got a vas cath. Yes, he's getting CRT. He's getting everything that can be thrown at him, but he's still refractory. Okay. So metabolic acidosis, remember, makes your patient present with refractory hypotension. It's the acidosis that creates the environment where you can't respond to the neurotransmitters. Okay, now the APP writes a note at 2200. This is where I'm saying this is where I got my information. So patients on norepi at 50, epi at 40, vaso at 0.04. Mental status got worse. He's working harder to breathe. He's breathing much faster than he was before, having ventricular ectopy, and his cardiac index drops down to 2.1. So it had gone up because he was on dobutamine, I think, or maybe he wasn't on dobutamine yet. But anyway, his cardiac index went from 3.5 to 2.1. That's from the arterial-based cardiac output measure. And his MAPs are 40. She does such a great job. She gives bicarb, she gives calcium, she gives MAG, she gives saline. Fantastic. And they decide to intubate. Anesthesia is called. They give him ketamine. They intubate him, and they do a chest X-ray to look for the tube. Okay. Now, because of this significant and worsening lactic acidosis, the concern is that he actually is infarcting his bowel, that he's got mesenteric infarct and ischemia, because this clinical condition is just not getting better. CRT, intubation, calcium, epi, norepi, vasopressin, volume, magnesium, potassium, everything you can give, he isn't getting better. So the concern is that he's got mesenteric ischemia, which is what's producing this profound metabolic acidosis. So they call for the acute surgical service to come and see the patient, and they do a bedside lap. This is not a trauma surgical ICU, by the way. They do an exploratory lap at the bedside. They open the abdomen. He has some peritoneal fluid because he's got interstitial edema, but at this time, no ischemic or necrotic bowel. But they say, yeah, you know, he's got a lot of venous volume. He's got interstitial volume. He's going to have abdominal compartment syndrome eventually. Let's just leave the abdomen open. We're going to put a temporary wound vac on him. They've got a good seal. So right now, this is what he's on: epi, norepi, vasopressin, amiodarone, ketamine, and heparin. Low intensity. And insulin, of course. Okay. He's a mess. He's a mess. Does he have a PE? Is that possible? Thinking about whether or not we should do some pulmonary vasodilation. I certainly don't think so. He's clearing his CO2, right? He has a high CO2 production, but he's clearing it. He's breathing well. He's clearing his CO2, pretty well oxygenated. Don't really think at this moment that he doesn't look like he's had a PE. I don't really, and I would agree. Let's not do pulmonary vasodilation. We're just going to make him muddier and muddier and muddier. Don't really have evidence of right heart failure. Echo says the right ventricle is mildly dilated, but I don't really have evidence of right heart failure. Going to put him on, going to continue on CRT. APP writes that it's net even. Nephrology actually says it's net positive. Okay, net even means all carrier fluids. That means everything that's carrying medication is removed every hour. So you're removing a certain amount every hour. Nephrologist says we're not removing anything and that he's net positive. So sometimes we just have a problem with our terminology. We want to be sure everybody is saying the same thing. APP says he's net even. I think he's probably net even. That means that the nurses are pulling carrier fluids every hour. So if he, with all his meds, he's getting 150 cc's an hour, that's getting pulled off every hour, because that's not resuscitation fluid. That's just carrier fluid, carrying the medication. I'm always going to take that off. If I don't take that off, I'm going to keep making the patient positive volume overload. So I don't want to do that. I want to remove carrier fluids. Okay. APP is very clear, talking with the family, really trying to maintain good communication with the family and communicate with them aggressively and actively. But I just want to remember, I want you to remember, nephrology wrote that the patient's net positive. APP wrote that he's net even. Now, here's the thing. all that volume, you're given all this volume with this medication. That's not resuscitation volume. You're going to make the patient worse if you don't remove carrier fluids. So you have to be sure that somebody has written an order, not a communication order, an order for you not to remove any fluids, including carrier fluids. Because if you're given 150 an hour for 24 hours, that's going to be almost 3 liters that you've made your patient positive, not with resuscitation fluid, but just with carrier fluid. Okay, second echo, 422. Left ventricle is still relatively normal, but now the left ventricular ejection fraction is reduced. He's now actually in pure cardiogenic shock with an EF of 20 to 25%. This is his chest x-ray. Okay, it's a little underpenetrated for my liking, but now I don't have any question whatsoever about that cardiac silhouette. It looks to me like I got a pretty big heart. Now, this patient is morbidly obese, so this may just be AP compression, and it may not mean anything in terms of his heart. He is morbidly obese by guidelines. Okay, cardiology says, hey, this is a patient that we know has had left bundle branch block. Fantastic. Thank you for telling me. He also had a PCI to his left circumflex. That's the side vessel going around the side lateral wall of the left ventricle and to the back, can supply the posterior surface. It's had very significant coronary artery calcifications. You can see them on his chest x-ray, on his CT, that you can see these calcifications. So he's got really rigid coronary arteries that are at high risk for poor blood flow. He has a troponin elevation, but they don't think it's related to coronary artery disease. That means it's classified as something other than acute coronary syndrome, which is called type 2 myocardial infarction. That's what we suspect. We didn't take him to the cath lab, so we don't know, but that's what we suspect. He's in refractory shock. Now he's got multi-organ failure. He had acute hypoxemic respiratory failure requiring emergent intubation. He's on CRT. He's got AKI on top of CKD. My God, he has so many things going wrong. He has a history of allergy to contrast medium. He didn't get any, but he also has a significant shock-induced liver injury. He's now in liver failure and is fulminant. He's got AFib. The cardiology says AFib with rapid ventricular response, and just concerned that he had an ischemic bowel. But is that something we're concerned about going forward? Probably so. Very complicated, really, really sick on norepinephrine, epinephrine, vasopressin, dobutamine. And his SVO2, which was 19, which then came up after starting on dobutamine, now has dropped down again to the 40s. And he has an EF of 20 to 25%. Okay. So at this point, you got to make some decision. He's 80 years old. He has a lot of comorbidities. Do I want to take him to the cath lab and give him a VAD? Is he a candidate for heart transplant? Does he need mechanical circulatory support, like with an Impella? Will giving him an Impella kill him? Probably. Will giving him a VAD actually give him a good life? Probably not. So lots of decision-making that has to occur. Wasn't involved in the decision-making. And I think the belief would be with his chronic kidney disease, his AKI, now he's got shock liver, he's got calcifications, he has a history of coronary disease. He's not a good candidate for any kind of mechanical circulatory support. So we're going to continue on with pharmacologic circulatory support. That would be epi, norepi, dobutamine, and adding in dopamine. Okay. Now I want you to look at these vent parameters. Okay. So this is really shortly after intubation and ventilation. He's on a 40% FiO2. He's on volume control, assist control. He's got very nice compliant lungs. His lungs look gorgeous. His lungs look gorgeous. He only needs 6 a PEEP. He's getting a rate of 20, and he's not breathing above the ventilator because he's quite sedated. He's moving very nice tidal volumes. He's got a great minute ventilation and a fantastic saturation. He does not have lung failure, and it does not look at this point like he's got a pulmonary embolism. Okay. But he has persistent, profound metabolic acidosis. Persistent and profound. The other thing that might cause that refractory hypotension is hypocalcemia, and he's got pretty significant hypocalcemia. So again, They're giving him calcium. They're doing everything right, everything possible. This is the note from nephrology at 1421 on 422, but I think the patient actually got, this is the time date, this is his file date, this is the writing date, but I think he got his fast cath on 421. And you can see he's got very high level dialysis, kind of a lower level of filtration, looking pretty darn good. And what he says is net positive, meaning you're not pulling any fluid. Okay, not pulling any, you're not pulling carrier, you're not trying to make them net even. So again, there's a little difference between what might be said by the APP and the nephrologist. This was his admission chest x-ray. Here's his chest x-ray today, 422. Okay. Coming to the end, my friends. So on 422, our MICU attending describes what happened to the patient in the beginning, right? Getting admitted with these vertebral injuries and the visualized vertebral injuries brought to our hospital because he's Jehovah's Witness, because the hospital felt they couldn't manage him in the ICU if they couldn't give him blood. He got that cold blue call because he had symptomatic bradycardia with heart rate 30 and he was hypotensive. He got epi and bicarb, atropine, got transferred to the ICU, got lined, got a VAS cath. Looks like he has type 2 MI, right? Type 2 heart disease, not acute coronary AFib, rapid ventricular response, persistent, profound, refractory metabolic acidosis. That's what kills him. That's what kills him. We can't control it. We just can't get it under control. We're looking for everything. We're looking at what's happening. We open the abdomen. We look for an ischemic bowel. No evidence, even though he does have malperfusion, he does not have an infarcted bowel. He gets dobutamine, he gets dopamine, he gets blood cultures, he gets respiratory cultures, he's on broad spectrum antibiotics, he's on an insulin drip. The belief is he doesn't have ketosis, but he's on an insulin drip. He has everything that you could possibly do for him. But now palliative care comes, which is so fantastic. And I wanted to put the palliative care's note in here because I thought it was just so beautiful and important. He describes the patient's illness, but mostly what he talks about is that the wife says that she was not that surprised when there was a discussion about code status. She says, I've been mentally preparing myself. I think it would be the right loving thing to do to make him a DNR, but the pain of letting him go, 57 years they've been together, the pain is overwhelming. I just thought that note was so incredibly important. Such a heartfelt, beautiful note. You can see it makes me emotional. And I wasn't even at the bedside. It just makes me feel so strongly about the beauty of our partnership with people who understand that we do the best we can to preserve your life, but that we also consider that a good death is really important as well. And so our APP, the APP who was communicating here, I know who that was. Probably most of the people on the call who were working with the patient know who that was. The most generous of spirit, lovely human being you could ever know, who's communicating with the family, communicating with the patient wife, the patient's son, and really talking about the patient's condition and our inability. And I would use his name, but this is a wide group, so I'm not using his name, but he does have a name, of course. Communicating with this family, discussing that the possibility of survival is absolutely not even 1%. There's just no possibility for recovery. And the decision is made, do not resuscitate. But the palliative folks, I love also with this little note, in the note that the palliative folks wrote, assured the wife that if she decides to make him a DNR, change his code status, this does not impact our interventions. We're going to continue to provide. We're not de-escalating. We're not withdrawing care. We're going to make sure he's comfortable. We're going to make sure you're at the bedside. We're going to give you love and support, and we're going to take care of your loved one. Remember, that's really the focus. Palliative care is not just about end of life. Palliative care is about assurance with families, making sure that we're doing our best to manage suffering, because no human being under your care in your family, in your life, no human being that you have influence over should ever suffer. And palliative care is about alleviation of suffering, not just about end of life, but about alleviation of suffering, family suffering, patient suffering. So I thought this note was just so extraordinary and beautiful. And the patient, so it goes, the patient, of course, does die. Acute shock that developed on 4/21 just continues to cascade and evolve. On 4/22, the organ failures and all the events that are sequelae from hypoperfusion and shock on 4/21 actually causes the end of our patient's life. He's in acute hepatitis with acute liver failure, acute on chronic kidney disease, cardiogenic shock, septic shock, most likely arterial hypovolemia shock. Don't think that he has distributive shock, because we don't think he has a PE and we're not using much PEEP, so we're not creating that. But the patient does actually die on 4/22. So I want to, I don't know why I'm so emotional. I must be hypoglycemic myself. Thank you, thank you, thank you. Every ounce of my heart. I'm so happy to be part of this family of nurses and APPs and physicians and all of our providers at the bedside. So thrilled to be able to share this story with you, which is a story of providing emergency room care in an ICU when you're not really certain what happened, doing everything possible to generate survival for this patient, and also appreciating the understanding and the knowledge that a time comes when we have to cut the tethers that keep our human body in that ICU bed beyond all suffering, that it becomes time to actually be able to say, we're going to let you go. We're going to let you go with peace and love. So incredible. Thank you. Thank you from the bottom of my heart. Thank you for forgiving that I'm an emotional person. I didn't take care of this patient, but I know everybody involved here. Thank you from my heart for everything you do every day. Thank you. I'm going to end the recording and I'm going to come back and we can have some discussion if you're interested. And otherwise, we'll sign off. But thank you so much. I'm going to end the recording now.